All right. Well, on behalf of Cook Children's, I would like to welcome everyone to part two of our Child Health Summit. We appreciate you, our community partners, for collaborating with us in our efforts to improve the health of children and families in our communities. We know that many of you joined us in November for part one, and so we thank you for sharing your time with us again. We have a busy agenda yet again today. We're excited to share more learnings with you from our needs assessment. Our agenda today includes our Cook Children's commitment, a quick recap of our CHNA methodology, with a special emphasis today on our qualitative and secondary data collection, as well as an overview of a motel survey of the hidden homeless families conducted by the Center for Transforming Lives. Blair Williams will present part two of our CHNA results. Since last November, we've been able to do a deeper analysis around our parent survey data from a health equity lens, and we've paired that with what we've learned from our additional sources of data. We invite you today to place your questions in the Q&A feature, or you may submit questions at any time in the days, weeks following today's event at the address on the screen, chnafeedback@cookchildrens.org. At this time, I would like to introduce Chris Pedigo. Chris is currently the Senior Vice President for System Planning and Healthcare Analytics for Cook Children's Healthcare System. Her team provides comprehensive analyses to board members, executive leadership, and physicians to inform the strategic direction and future decision-making for the organization. Additionally, Chris oversees the Center for Children's Health, which consists of programs created to positively impact children's health and safety across its primary and secondary service areas. Chris works with numerous local collaborations and community groups on children's health issues. She's involved in grassroots advocacy and public policy initiatives and serves on many coalitions and boards. Chris has an undergraduate degree in nursing from TCU, a master's degree in healthcare administration, and has been employed with Cook Children's for 32 years. Welcome, Chris.
Thank you, Becky. Sounds like a lot of accomplishments that so many people helped me along the way be able to attain. So good morning to everyone. This is what a morning for a health summit when we have such lovely weather outside to be excited about. That's why I chose my background of a nice sunny sky in front of our lovely medical center, and that's the background I thought would be best for today. Again, thank you, Becky. Thank you for all of you joining us. Thank you for taking time out of your day. I know this is a commitment, and I really feel like the efforts that the team has put towards this project, towards fulfillment of the assessment, and all of the work, the tremendous amount of hours, partnerships, discussions, meetings that we've had is going to allow us to do two things. One, fulfill the promise of Cook Children's, which is knowing that the life of every child is sacred. We want to prevent and address and treat illness and injury. There have been many opportunities for us to develop implementation strategies in the past from previous CHNAs, and this is just another one of those efforts. We have taken the data that community leaders have provided, parents, populations that may have not had a voice in the needs of children's health. And we want to make sure that we take that information and combine it with the very important secondary data that you all will see today and develop strategies that we feel very strongly about that will help us address the needs of the community. I want to thank Becky's team publicly, Terry, Rashida, Linda, Blair Williams, who we'll hear from later today on some of the data, and just the leadership of Marilyn and Becky to help us achieve all that we have done, and just very much appreciate the countless hours that this has taken to fulfill. I want to also thank, as did Becky, our community partners. I know that there's a great survey that Carol and her team have had in the field, and really look forward to learning about that. The partnership of UNT Health Science Center, and again, just the efforts of everyone on the call and everyone who has contributed to this CHNA, this time, and these amazing strategies that we have to develop and share with our leadership. later in the month of April, I will take all of this information to the highest level within our organization for their approval and to make them aware of the strength of our commitments and the power of partnerships in our community so that we can take care of children who need a voice, and we want to be that voice for them. So thank you again. I will turn it back over to Becky, and you can finish up the next introduction.
All right. Thank you, Chris. I would like to, at this time, pause and recognize our numerous supportive community and research partners. And as Chris was thanking everyone earlier, I think I want to just take a minute to recognize just all of the different groups of individuals that have been very instrumental on our CHNA journey. Thank you to Linda Fulmer, our CHNA administrator, and a big thank you to our research partners, ETC Institute, MHMR of Tarrant County, University of North Texas Health Science Center School of Public Health, and the Center for Transforming Lives. I'd also like to thank the many internal departments within Cook Children's who have been very instrumental on our CHNA journey. A special thank you to the leaders and staff members within the Center for Children's Health, particularly Chris Pedigo, Marilyn Napier, and also Terry Ford, Rashida Parikh, and Blair Williams of our Child Health Evaluation team. This year, we brought together an external advisory committee made up of community partners representing the 8 counties within our service area, who graciously shared their time and insight with us as we were finalizing our parent and community leader surveys. And then they also spent time creating awareness of our surveys and focus group opportunities during data collection, and some provided community leader interviews for us. So thank you, external advisory committee members. We expanded our 2021 CHNA methodology this time around, and I encourage you to visit our website at centerforchildrenshealth.org. We provided some FAQ documents and created a short video that provide detail around our data collection methods. And I'll just provide a very quick recap before we move into the rest of the session today. We conducted a parent survey, which was a random representative survey of parents and caregivers with children ages 0 to 17 across our 8-county service area. We administered this survey through phone, email, and mail. We then, MHMR conducted this same parent survey through interviews with caregivers experiencing homelessness or with an undocumented status. UNT Health Science Center conducted focus groups with families to gather a deeper layer of information, and they also provided secondary research to look at national, state, and local trends. And Dr. Stacey Greiner will be sharing more about this later in the presentation today. We administered a survey among leaders across different sectors such as city, county, government agencies, public health, nonprofits, school districts, and businesses working in our 8-county service area. And we then followed up with face-to-face interviews with more than 20 community leaders. And then finally, we were also able to utilize some very helpful results from families living in motels conducted by the Center for Transforming Lives. We are so grateful for the Center for Transforming Lives for allowing us to highlight their survey results within our needs assessment. Their motel survey illuminated the unique needs of an often silent or unseen homeless population within our community. And before she shares, I would like to introduce Carol Klosick. Since 2009, Carol has been the CEO for the Center for Transforming Lives, which works alongside women and children to disrupt the cycle of poverty by providing comprehensive homeless services, early childhood education, and economic mobility services. Carol holds a master's degree in social work from the University of Texas at Arlington and a master's in business from Texas Christian University. She serves as a board member for Downtown Fort Worth Incorporated, UNT Health Science Center's academic community partnerships, and has served on boards that address homelessness, mental health, and maternal and child health. Welcome, Carol.
It's great to be here. I am excited to share these results with you. this morning and tell you what we've learned. So before I start to tell you more about what we found, I want to say special thanks to the Center for Children's Health at Cook Children's, who provided financial support for the survey, as well as the family committee within Tarrant County Homeless Coalition, who helped us put the survey together, and then Dr. Erica Thompson, who served as a wonderful advisor and editor on the document that will be published next month. So let me also give you a little bit of background about why we conducted this survey. So as some of you may know, we published a report in 2019 that really looked at the experience of homelessness for children. And in that survey, or in that report, we looked at that overall population. And that involved 39 different agencies operating in Tarrant County who are serving that group, and looked at that overall picture, which led to this deeper dive just on children who are living in motels. So next. So first, let's talk about the different definitions. One of the things that really makes life complicated for children and families experiencing homelessness is the different federal definitions. So we have one definition that really comes from the U.S. Department of Housing and Urban Development, because what they're trying to address through their homeless services programs are really those living in camps, in shelters, on the street. And so for families, that counts children who are in families who are living in shelters, in camps, and in cars. But it's the Department of Education that really captures the children who are experiencing homelessness or housing instability by living with other families when there's no permanent agreement. Sometimes those are known individuals, sometimes they are more just an arrangement of convenience. Families who are enrolled in homeless service programs such as permanent supportive housing or rapid rehousing, those families are not considered homeless under HUD, but are considered. And then families living in motels. So it's a bigger picture, and what we've seen is an increase in families or children who are who meet that definition, while that HUD definition group has continued to decline. But so we've done the original report in 2019. We did a journey mapping report after that looked at the experience of those families. And what we found is that this is a group that's fluid. Sometimes they live in cars, sometimes they're in camps, sometimes they're in shelters, and sometimes they're in motels. So that kind of variability can make it very easy for this group of families and children to fall through the cracks. So when we look at this slide, you can really tell where that group falls. So if what we saw for that 17 to 18 time frame is that of the 15,000 children that are living in homelessness, about 15% of them live in motels. So that's the population that we're really zeroing in on today. Overall, that represents about 2,600 children that are experiencing life in a motel during the year. Okay, next slide. So that we conducted in-person surveys as well as using a QR code. We collected altogether 70 surveys, and in order to successfully complete the survey, they had to have at least one child under the age of 17 in the household that was in the motel. I can tell you that it was very challenging to do this. The families that we spoke to were willing to participate, particularly because the surveys were anonymous. But it was the property managers themselves were very reluctant for us to come in to do the surveys, and often denied having families that were living there on a permanent basis. But because we had partners, police departments, food bank, and so forth, we were able to capture this. And the 70 surveys represented a total of 240 individuals. So the average family size was 3.4. Some family or rooms of particular concern were two rooms, which had 3 generations of one family living in the one room, and one room where 9 individuals were. It was 3 families, so very, very crowded conditions. And then so that really gave us the picture of what life was, how complicated life was for these individuals. And a third of the families included children under the age of 6. The racial and ethnic composition reflects that of the overall, or is similar to the overall homeless population. And so although we do see that Black families are overrepresented here, just as they are in the homeless population as well. So one of the really surprising findings is just the length of time that these families are living in motel. More often than not, they were living in the motel for 6 months or under, but we did see about 25% that were living in the motel on a full-time basis, so 1 or more years. So that's a tremendous amount of time and a very unstable living situation, which presents quite a bit of challenges that you'll see in the following slide. One interesting note is about half of the families are receiving their mail at these motels. So despite the fact that the property managers often said that the families were not living there permanently, clearly, if they were receiving their mail, there they are. What we found is that the families, and then they were able in the survey to select more than one response, but their number one need was food assistance. And food assistance came up in several of the conversations, but that really demonstrates a tremendous amount of food insecurity for these families. And then an equal number indicated they needed some form of rent assistance or some form of income that will help with rent. It was also just a note, it's not a significant part of the population, but among the unmet needs are medical attention. So what we really see with these families is just that they are quite isolated from and separate from the service delivery system. And I'll talk more about that, where they've tried to seek help in the next slide. So a lot of these families are seeking assistance with food. It is, and as we saw the situations and heard about their situations, it makes so much sense that food storage is a problem, food safety is a problem, because they have to be able to prepare food safely and store it safely, which most of these motels, of course, don't offer anything for them in that way. So finding food on a day-to-day basis is very difficult. And so that's one of the things that we really see, that children, of course, are relying on the food assistance in the schools for their daily nutrition needs. They also did have, many of them, about a quarter, did attempt to seek assistance through the homeless services system. And then later we'll talk about a little bit of those barriers. But a surprising number of those individuals who were living in motels had not sought any assistance of any kind. So again, really underscoring their separation, isolation from the service delivery system. Okay, next. So when we were asking them about their awareness of resources, we saw that they were not at all familiar. Many of the families were not at all familiar of the kind of resources that they might be able to access through the school district, or had some degree of awareness, but just not as much as we would like to see for families that are so very vulnerable. What we did also see is that, I think this is on the next. No, sorry, it's not on this next slide, but the number one place for families that were able to seek assistance, the number one source of that assistance was through a school counselor. So they were less likely to seek assistance or to obtain assistance through a homeless liaison within the district because of these. We recognize that that the homeless liaisons within the school district, there are so few of them, and it's very, very easy for those individuals to become overwhelmed with the amount of need. But at least when the children are of school age, they are getting connected to a limited amount of assistance through the school counselor. So. I think, as we've been talking about, it's really important for these children to be engaged in school so that they can have access to the nutrition that school offers, as well as the assistance. We are publishing this report in full in the month of March. We'll have recommendations, but of course, what the number one recommendation is to really look at the way that those definitions impact children and the ways that providers might do outreach to the area motels to engage these families in services to meet those really pressing needs. So I think I've got a little bit over on time, but I appreciate the opportunity to bring these results to you. And there's my contact information if you've got any follow-up questions, or if you would like a hard copy of the publication when it is ready for distribution.
Thank you, Carol. As you all can see, this survey really provided helpful insight to those unique challenges that these families are facing within our community. So thank you all for conducting and sharing your results with us today. At this time, I would like to introduce Dr. Stacey Greiner. Dr. Greiner is an assistant professor in the School of Public Health at the University of North Texas Health Science Center. She teaches in the maternal and child health program, and her research focuses on prenatal care and oral health. Her passion involves translating her research findings into innovative, evidence-informed, patient-centered interventions targeting young adults, healthcare providers, and community settings. Stacey worked alongside a team of others from the Health Science Center, conducting focus groups and gathering secondary research for our community health needs assessment. She'll now share more around these data collection methods. Welcome, Dr. Greiner.
Good morning. Thanks again for having me. Appreciate the introduction. I am Stacey Greiner. I'm also the program director for the Public Health Leadership Master in Public Health program at the Health Science Center. Today, I'll be talking about the methods that we use to conduct focus groups with parents and the sources of community indicator data that we analyze to provide some context to the CHOPS results and contribute to the overall community assessment. Some of the contributors on this project were Danielle Rohr, Dr. Emily Spence, and Dr. Eric Thompson. So our team collected data through focus groups and located community indicator data related to child health. I'll be talking about the methods that we used in this presentation. These data sources were then synthesized with the parent and leader surveys to help us understand the health needs of the community. We will first start today by talking about some of the methods that we used for focus groups. Some of you may already know about these methods, but I want to make sure we're all on the same page. So what is a focus group? Focus groups involve interacting with a small group of people. In this case, it was families in the local community. The research team shared a prompt and then asked this family group made up of parents to discuss the topics that are related to children's health and healthcare. Focus groups are valuable for giving us contextual, in-depth understanding of our community indicators and the survey data we have. And although focus groups typically have a small number of people, the interactions and the feedback provided by the participants can help us better understand the nature of barriers and experiences in healthcare. How did we enroll participants? We partnered with Cook Children's, who referred parents in their community networks to participate in focus groups. And we also shared the announcements on social media with local partners. We reached out to people in all 8 counties. How many people did we talk to? We conducted 6 focus groups in total and 1 interview. In total, there were 22 parents involved, and families in the focus groups were from Tarrant, Denton, Wise, Parker, and Johnson counties. We conducted these focus groups using Zoom in April of 2021, and participants were given either a Walmart or a Target gift card for participating in the focus group. We framed each focus group within the social determinants of health framework, which seeks to understand the social and economic contributors to health. Each focus group then had a specific topic area. One area was physical and oral health. In focus groups about that topic, parents discussed nutrition, physical activity, and dental care. In the safety and wellness focus groups, parents discussed safety and injury prevention and also abuse and neglect prevention. One focus group was around mental health and interactions with the mental health care system, and the final topic was asthma. In all focus groups and interviews, parents discussed COVID's impacts on child health and healthcare. The questions and discussions started broadly with questions about overall health needs and access to care issues. One example question is, what is the most important healthcare need for children in your community and why? And then for each specific topic area, we discussed the needs, barriers to care, sources of information about the topic, resources and services available in the local community, and the methods of prevention. The focus groups were about 90 minutes each. They were audio recorded through Zoom, and then we sent them off for transcription. Once we reviewed the transcripts, we identified the themes that came up within these focus groups. And once we had identified the themes, we then identified quotes from participants that represented or best summarized the theme. And you'll hear more about the results in just a bit from Blair. Now I'd like to switch gears and talk a little bit about community health indicators and the methods we use there. What are community indicators? Community indicators are data or information that have already been collected and made readily available for researchers and communities to use. This can include things like public health data, academic sources, or even school level data. We systematically identified the community indicators that align with the CHAP survey questions so that we could compare our local community to national, regional, and state data. Additionally, we were looking to identify any health disparities that may currently exist in the nation or within the state to explore further in the local community. What kind of indicators did we look for? We prioritized zip code and county level indicators, but because child health data can be limited, in some cases we use regional or state level data as an alternative. Overall, we were identifying community indicators related to abuse and neglect prevention, access to care, asthma, COVID-19, healthy lifestyles, which includes obesity prevention, mental health, oral health, and safety and injury prevention. One of the community indicator sources that we utilized frequently was the National Survey of Children's Health. For this data set, parents of children ages 0 to 17 across the US were surveyed, and data are reported at both a national level and a state level. We utilize indicators from 2019 to give us a pre-COVID baseline, and then use 2020 data to provide information about children's health during COVID. These data are useful as most of the items from the survey directly parallel items that are in the CHAP survey, so we could make comparison. And also the data addresses many health topics. As you can see on the bottom of your screen, for this data source, we were able to find information related to all of the health topics except for COVID. The Youth Risk Behavior Surveillance System, often called the YRBS, is the next data source we utilize. This survey collects data from high school students within school systems, and these data are from a national, state, and local level. One of the regions where local data is collected is the Fort Worth ISD. The most recent data from this survey are from 2019 and provide us with a pre-COVID baseline. This source of data is useful because it provides information about a broad variety of health topics and behaviors, including asthma, healthy lifestyles, mental health, oral health, and safety. We also utilize many indicators from the Centers for Disease Control and Prevention. This includes indicators from many surveys, both at a national and a state level. Some of these data sources include the National Vital Statistics System, inpatient hospital data from the Agency for Healthcare Research and Quality, and the web-based injury statistics reporting system. We utilize this data source because it's collected regularly, so we are able to see trends over time, and we can compare these to national baselines. From this, we reported on indicators about asthma, access to care, COVID-19, and safety. We also prioritize state data sources to provide us a Texas baseline and determine how our local community compares to the larger state. Some of the sources include the Texas Department of State Health Services, the Texas Immunization Registry, and the Texas Department of Family and Protective Services. We reported on state level indicators about immunizations, safety issues such as water safety, lead poisoning, and safe sleep, COVID cases and immunizations, and confirmed reports of abuse and neglect. In the local community, we use data from the Cook Children's Healthcare System, including the Healthcare Analytics and Trauma Registry departments. The data that we used here was from 2017 to 2020 and included information about medical visits, emergency room utilization, and hospitalizations. This provided information and context about the health concerns in the local community. Finally, some other data sources that were more specialized include the American Academy of Pediatric Dentistry for indicators about oral health, the Healthy Tarrant County Collaboration and the World Health Organization for indicators related to healthy lifestyles, and the County Health Rankings and America's Health Rankings from the US Census Bureau for indicators about access to care. So to understand the needs of our community, we synthesize the data from the focus groups, the community indicators from all of the sources I just talked about, and then the data from the parent and community leader surveys. Our process was to start with one health topic and then compile a report summarizing these various data sources. We then sent this draft to stakeholders at Cook Children's for their feedback and incorporated that into the draft. Once the reports for each topic were drafted, we summarized the overall findings and the areas of success and concern that we identified. As the Cook Children's team is currently finalizing the report, they've also included information from the community leader interviews that their team conducted and data from the motel survey conducted by the Center for Transforming Lives. Blair will share more about this in her presentation. The information from the focus groups and community health indicators provide us with context for the results from the CHAP survey. Both of these help us tell the story of children's health in the local community. Thanks again for the opportunity to summarize the focus group methods we use and discuss the community health indicators that will be included in the CHNA. Appreciate all of your time.
Thank you, Dr. Greiner. Oh my goodness, the expertise and the support of UNT Health Science Center has just been so valuable to our CHNA this time around. So thank you to you and your team. All right, well, at this time, we're going to share some more results with you all. I'm going to introduce Blair Williams. Blair is a child health evaluation analyst at Cook Children's and our Center for Children's Health. And for the past 15 years, her expertise and passion for public health has been focused on child and family health. In previous roles, she served as a community health educator, advisor to healthcare and school administrators, a developer of family-centered community wellness programs, and researcher for family wellness behavior. Blair brings her experience, enthusiasm, and love for data to our community health needs assessments, program evaluation, and community benefit reporting. She loves supporting Cook Children's and community stakeholders so we can all bring joy and improved health to every child. And if you know Blair, you know the joy and the energy she brings to just about every single thing she does. So take it away, Blair.
Thank you, Becky. I'm hoping that everyone can hear me okay. It is an honor to be here today to present some of our key findings of our parent survey, and also pair that with some really great quantitative and qualitative data that we collected along the way from our community leaders, as well as our parents and caregivers across our 8-county service area. So we're all here today with the same question in mind. And if you could go to the next slide, we'll see what that question is. How do we help every child with their health needs? That's why we're all here today. And this connects with our Cook Children's Promise, where we're trying to improve the health of every child in our community. In our 8-county service area, we have over 1.2 million children and a total population of over 4 million. So how do we help those children with their health needs when it's a diverse population? And that's the questions that will help answer today in today's presentation. Next slide. For today's presentation, we include many of the data sources that our previous presenters had mentioned. We're focusing on that parent and caregiver survey findings of our 8-county service area children ages 0 to 17, and also the findings of our face-to-face survey of those underserved children that were either at a homeless shelter at the time of the survey, or they had at least one undocumented family member. Again, these are children ages 0 to 17 across our 8-county service area. We also conducted that community leader survey, which was mentioned earlier in the other presentations. That community leader survey had over 300 responses from our 8-county community leaders. And that allowed us to get a really good sense of what they were concerned about, any needs that they identified in their community through their work. And then we follow that up with interviewing the community leaders on an individual level. So we were able to talk with them, ask them more in-depth questions, and this provided a really great depth to our understanding of the survey and what we saw on our caregiver survey results. UNT and their team also did those focus groups with caregivers that Dr. Greiner had mentioned in her methodology review. And so between the community leader interviews and the focus groups we conducted with our caregivers, we were able to supplement our caregiver findings with really great qualitative data. I will be sharing some of the key themes and quotes from that qualitative data. Just know that as I'm presenting them, some of them have been shortened so that I could communicate a lot of the key information with you today. And I've also removed any identifying information of those caregivers or community leaders because we respect their privacy, and more thankful for their participation in our qualitative review, especially during a pandemic. So thank you to everybody that has supported this, including the parents and leaders that participated. We'll also supplement, can you go back one more? Thank you. We also supplemented some of the findings that Carol had mentioned, and you'll see some of those findings in this presentation as well. And again, this is a high level presentation, so it's not nearly everything that we found. It's just really great information that can help everyone address those equity gaps that we identified today. For more information, I'd encourage you to visit our data dashboard, review our full CHNA report, or give us reach out to us and we'll be happy to help you. Next slide. Okay, so in our most recent CHNA report that we're finalizing, the following community health needs were identified. These are needs that are ongoing, we've identified in previous reports, but the thing that we're really highlighting this in this report and in this presentation is that these are all intersected, that they are all connected. And at the center of it are what we call social determinants of health. And Dr. Greiner had mentioned that in her presentation, that where a child lives ultimately determines their health. And that's going to be the core of this presentation. And you're going to see those common themes and these health topics intersect across the remaining part of this presentation. Next slide. And so if you haven't heard the term social determinants of health before, this is a term that's used to identify that where a person lives ultimately determines their health. And for children, where they live, learn, play, and grow impacts their overall health. Again, these are going to be concepts that you'll see throughout the rest of the presentation. Next slide. Okay, so we've got a lot of data, both quantitative and qualitative. We have this understanding of social determinants of health, and we're all here today because we want to help every child with their health needs. So what better way to frame all of this that we're about to present than with an acronym? And if anyone knows me, they know that I love acronyms. So we're using the HELP acronym today. HELP is the concept of that it's health first, and we want to focus on equitable access to care and basic needs. The next part of that acronym is environment. That's safety, where children live, learn, and play. The next part of that acronym is learning. That's readiness and support for academic success. And the fourth piece of that is parenting, and that includes parenting and family support. So we'll use this framework to organize all of our findings and help you be able to help every child in their communities. Next slide. Okay, so we'll begin first with health. Again, this is equitable access to care and basic needs. On our caregiver survey, we had multiple health topics that we were assessing. And so for this section, we're looking at health status, oral health status. Did they receive all of their needed care? Did they have preventative visits for their well child or for their oral health? Did they receive family-centered care? Are they able to get food that they need? Did they visit the ER because of their asthma symptoms? And we also look at their BMI. Next slide. Okay, so let's first start with their health and oral health status. For children in our 8-county service area, most are generally healthy according to their caregivers. So for children ages 0 to 17 in our 8-county service area, 7 and 8 have excellent or very good health according to their caregiver. But if we look at that 1 and 8, how many children is that? In our 8-county service area, we're able to estimate that that's 147,000 children who do not have excellent or very good health according to their caregiver. And if we take a look at oral health, 3 and 4 have excellent or very good oral health, which is the majority. But for that 1 and 4, that's 312,000 children that we can estimate. We're looking at children ages 1 to 17 here for the oral health, since that's when they have their teeth. But we could see here from our data how many children have health needs. And we're hoping that we could carry this through the rest of the presentation and provide helpful data to help support this. Next slide, please. Perfect. So let's first look at how many children didn't receive the care they needed. So according to caregivers of children 0 to 17 in our service area, 1 in 4 children did not receive all needed care for their health, dental, or mental services. That's 1 in 4 children. If we take that and estimate it to our population, that's 353,000 children that did not receive all of their needed care in the past year. Now, of course, we did have the pandemic, and that was one of the top reasons why parents told us they weren't able to get the care. But second to that is they didn't have insurance that was sufficient to cover the cost of their child's care, or services weren't available in their child's area. If we take another look at some of the other types of questions we had on our parent survey, we also saw that 1 in 4 did not always receive family-centered care that was sensitive to their family's values or customs. When a caregiver goes to a provider, we want to feel connected to that provider. 1 in 8 did not have a well child preventative visit in the past year. That is an opportunity to connect with that doctor to help not only with that child's health needs, but maybe how they're doing in learning in their education environment, also to help with social needs if they need food or other services. 1 in 10 did not have continuous insurance coverage in the past year, which means they could have had a gap in coverage where they simply didn't have insurance throughout the past year. And although 1 in 10 didn't have insurance coverage, some of those that were insured and covered with insurance may not have been able to still afford the cost of care. Next slide. Okay, so these findings were supported and were, again, common themes that we heard from parents and leaders in our qualitative focus groups and interviews with leaders. Access to care is limited for children who are living in non-urban areas have Medicaid or have undocumented family members. We heard from parents that they had to drive 30 to 40 miles just to see a doctor that accepted their health insurance. And if they didn't have transportation or transportation was limited, that really makes it difficult to get the care that their child needs. We also heard from community leaders who said that for those that were undocumented or Spanish speaking, they were a little bit hesitant to get the care they needed because they were afraid that they might get deported or reported to an outside agency if they sought care. And for mental care, it was simply overwhelming. It's just where to start. Parents told us they didn't know where to go. Should they go to a guidance counselor at school, a psychiatrist, or a doctor? And just not knowing where to start kept them from starting that initial visit. Others, including caregivers, had to miss work, and students had missed school for their doctor's appointments. We heard from a parent that said that they had to miss so much school to take their children to doctor's appointments that even the nurse and front office lady at the school had let her know that they were missing a lot of school. Next slide. So if we look at access to basic needs, and we're looking at what community leaders told us on their survey. Again, this is a survey of over 300 leaders from across our 8-county service area. Over 60% of those leaders felt that poverty and affordable housing were serious problems for children in their communities. And we heard this in the leader interviews as well. There is a distinction between the haves and have-nots. Heard that multiple times through different interviews. We also had concerns about housing, that housing is difficult to find. For low-income families, the wait list to get into low-income housing was so long that they couldn't get in. And for middle-income families, they couldn't afford the housing that was available. And so for many, if they couldn't find housing that was affordable, that meant that they had to live in their cars or motels or share common spaces with other families. And a leader connected how important housing was to the overall health of their children and their community. They need to have that stable housing in order to make sure that they have good health and safety in their home environment. Next slide. So if we look at our results by household income, we asked on the caregiver survey if they could provide their income. And we had 8 different categories. For the purpose of today, we're looking at them in 4 different categories. We're looking at below 50,000 annual salary, 50 to 100K, 100 to 150K, and 150K plus. If we look at our sample size of our caregiver survey, nearly 1 in 4 children live in households with an annual family income below 50,000. That's an estimated 300,000 children in our 8-county service area. When we take a closer look at their health, we saw that 18 times more likely to be food insecure, meaning they couldn't always afford the food that was most nutritious to them. They were 12 times more likely to visit the ER for asthma symptoms. They were less likely to have excellent or very good health status. They were less likely to receive family-centered care, and they were less likely to receive all needed medical care. We heard from a community leader that said families have to choose. They either have to choose medicine, food, housing, or even just necessities for their children. And others couldn't even make it to the grocery store if they didn't have the proper transportation. Next slide. Now, if we take this a little bit broader, and instead of just looking at that below 50K category, now let's look at below 50K and up to 100K. So we're looking at children from 0 to 100K. In our 8-county survey, 8-county service area, our sample size, we see that there's 3 in 5 children who live in households with an annual family income below 100,000. That's an estimated 700,000 children in our 8-county service area who live in an income below 100K. If we look at their health compared to higher income families, they're less likely to have excellent or very good oral health, less likely to receive that well-child visit or all needed medical care. They're more likely to be food insecure, and they're less likely to have a normal BMI for age. The children in our sample who had an overweight or obese category for their BMI had also higher rates of food insecurity. They weren't able to get nutritious foods. They also weren't able to access areas where they could be physically active. So for children in households below 100K, we do see an impact to their overall health. And from our community leaders, they told us that the COVID pandemic was so disruptive that it really impacted everyone's basic needs and access to health and healthy foods. Next slide. Okay, so here we're going to look at equity gaps when we're looking at this health category. And here we could look at it by age group, race and ethnicity, and for our underserved population. For children that are ages 0 to 5, they were more likely than the older children to visit the ER due to asthma symptoms, and they were nearly 3 times less likely to have a preventive dental visit. For our school-age children, they were less likely to have that ideal oral health status or a well-child visit in the past year. And for our 12 to 17-year-olds, they were less likely to have the ideal health status according to their caregiver. And this could be tied into some of the other categories we'll discuss here in a moment, but it's important to see how age groups also have equity gaps. In our 8-county service area, we also found equity gaps for children of color. We use the 5 categories you see here listed on the slide: is Hispanic, non-Hispanic Black, non-Hispanic White, non-Hispanic Asian, and non-Hispanic multi-race. This aligns not only with the census, but it also aligns with the National Survey of Children's Health. So we're able to compare our local level data with national and state benchmarks. Our Hispanic and non-Hispanic Black children respondents were less likely to report ideal health status, ability to afford healthy, nutritious food, and they were more likely to visit the ER due to asthma symptoms. For children of color, that's every color with the exception of non-Hispanic White, they were less likely to report that they always received family-centered care. For our underserved children, again, these were the families that were interviewed face-to-face at a homeless shelter, or they had at least one undocumented family member. They were far less likely to have the ideal health status or oral health status or food security, and they were much more likely to visit the ER because of their asthma symptoms. So as we explore findings in the additional sections of this presentation, we could see how social determinants of health really impact some of the results that we're seeing. Next slide. So to summarize the health section, how do we help every child with their health needs? To summarize some of the things that we heard in this presentation, we want equitable access to family-centered healthcare for children. That includes preventative services and prompt treatment for their health, dental, and mental care. Also, access to basic needs such as housing and food. And while I highlighted a lot of quotes on needs for this presentation, I'd like to also point out that community leaders told us about how the community really responded to the needs in their community when the pandemic hit. And here is a quote. It says, "The pandemic impacted basic needs and food. Our community really stepped up to the plate. Churches and programs helped young kids with food and adults who may have lost their jobs. We're proud of our community." And the community really came together to recognize that these are needs, and there's multiple organizations and partners addressing these needs. Hopefully this data for the health section will be able to help address some of those health equity gaps. Next slide. So the next section of our HELP acronym is environment. And environment is safety where children live, learn, and play. In this section, we're looking at the ER visits due to accidental injury. We're looking at first childhood experiences, and we're looking at neighborhood and school safety. Next slide. Okay. So first, we'll look at accidental injury. So according to caregivers of children 0 to 17 in our service area, 1 in 8 children received emergency care for an accidental injury. That's 148,000 children. Now, I'll pause on this slide for just a moment to say that this is an estimate of the children that were injured and received emergency care. There could have been children that were injured and for various reasons weren't able to receive emergency care if needed. If we look at leading causes of injury in the United States and Texas, we see that for infants, suffocation at unsafe sleep environments is the most common. For children 1 to 4 years, it's drowning. For children 5 to 17, motor vehicle traffic accidents. And for young children and teens, poisoning and firearm injuries. When we heard from our parents and our community leaders, parents were concerned that these accidents could just happen in a moment's time. If you just turned your back for a moment, this is when an injury could occur. For leaders, they wanted to make sure that children were in car seats, and that if they were at any lakes or open bodies of water or swimming, that they had life jackets available or they had water safety lessons to them. And others were concerned that, especially during the pandemic, when so many parents had to work, if children are home alone, that presented an opportunity for them to receive an accidental injury. Next slide. For our next safety element, we'll look at what's happening in the home. And for this metric, we'll look at what ACEs we estimate in our community. If you're not familiar with the term ACEs, it's for adverse childhood experiences. And it's events that were potentially traumatic, things that happened to a child in their childhood. And for our 8-county service area, children 0 to 17, 1 in 7 children has 2 or more ACEs. You're probably wondering what those ACEs are, and examples of them are listed below on this slide. So we have parent or guardian divorced or separated, lived with anyone that was mentally ill, suicidal, or depressed, lived with anyone that had a problem with drugs or alcohol, parent or guardian served time in jail, witnessed violence in the neighborhood or their home, had discrimination, or a parent or guardian died. So 1 in 7 children, according to what our caregivers told us on survey, have 2 or more of these experiences. On our community leader survey, the ACEs that had the most highest concern for our leaders were those children that were living with anyone who was mentally ill, suicidal, or depressed, or had problem with drugs and alcohol. When we spoke to leaders about home safety, we heard this several times, that the COVID-19 pandemic itself should be considered an ACE because it was so disruptive to our normal routines and safety and basic needs. Others were concerned that if children were in abusive households, whether that was physical or emotional, those were impactful and would last with that child until adulthood. Others connected this concept of ACEs to a child risk behavior or substance use or their overall mental health. And others pointed out that children could show that there's something going on in the home by coming to class and showing signs of depression or acting out or fighting. And those are all warning signs that something could be happening in the home, indicating it was not a safe environment. Next slide. And so if we look at safety from that household income lens, again, using that same 4 categories, and we're looking at children below 50,000 as their annual income, they are 5 times more likely to have at least 2 ACEs. They were less likely to feel safe in their neighborhood or at school. For our infants in this income category, they were less likely to sleep alone in crib, which is the recommendation for safe sleep environment. For ages 1 to 4, they were less likely to be within a reach of adult during swim, but they were more likely to be within reach during bath time compared to children in other income groups. And if we look at all ages, their families were less likely to safely store firearms. In 2020, firearm sales nearly doubled in the state of Texas, and many of those purchases were first-time gun owners. So there may be that they don't have access to a safe or a lockbox for this firearm. For our community leaders, when we interviewed them and asked them about this, they were concerned that there was an increase in trauma for children, and for those that had unsafe or unstable living environments, meaning they had to go to maybe live in their car or share with other people, that posed a very large risk to their safety. Others were saying that because they had to share small dwellings with multiple families just to be able to afford cost of living, that posed some concerns to sanitation, mental health, and safety. And in terms of safe sleep environments, infants were often sharing sleeping locations with siblings or adults, and that poses a threat to their infant mortality rates. Next slide. So if we look at equity gaps for this section, we look at age groups first, and we see that the likelihood of being receiving emergency care for accidental injury was highest in the 0 to 5 and 12 to 17 age group. And for our 12 to 17-year-olds, they were more likely to have 2 or more ACEs compared to the younger children. If we look at the likelihood of receiving emergency care for accidental injury, it was highest with our non-Hispanic white respondents. Although this may mean that they have better access to healthcare, were able to get the emergency care they needed for their accidental injury. For our non-Hispanic Black and non-Hispanic multi-race children, they were more likely to have 2 or more ACEs compared to the others. And for our underserved population, they were 3 times more likely to have 2 or more ACEs. Next slide. So to summarize the environment section, how do we help every child have safety from harm? To provide equitable access to family-centered healthcare that includes emergency care or injury prevention resources, such as car seats, life jackets, safe sleep environment, lock boxes for firearms or medication, access to safe, stable housing and food, and parenting and family support. Our community leader said that the community was engaged and did a great job responding to the needs associated with the pandemic around food insecurity and rental assistance. We also heard that child advocacy centers saw an increase in case volume, and that was to be expected with the pandemic, but they were high functioning and did a great job responding to the needs of children. Next slide. So for this next section of our HELP acronym, it's learning. We're looking at readiness and support for academic success. And here we'll look at school readiness for 3 to 5-year-olds, developmental delay, learning disability, and mental health. Next slide. If we look at children ages 3 to 5 in our 8-county service area, we asked caregivers how confident they were in their child's developmental readiness for school. 1 in 8 children may not be developmentally ready for school based on their growth and skills. This is based on what caregivers told us. This is an estimated number of 24,000 children across our 8-county service area. And this local rate, when we compare it to what we see at the national and state level, is the rate of those that aren't ready is much higher compared to that. And some of the concerns that we heard was that if children weren't around members of their own age group or in the classroom structure, they weren't having that opportunity to get that socialization. And it was a missed opportunity to have the developmental screening or any developmental milestones that weren't met. And again, from our parents, they weren't really sure where their child should be in that stage of development. And then if they did identify any concerns, what would they do with that information? Next slide. If we look at older children, so we're looking at ages 3 to 17, and this is based on what caregivers told us. 1 in 10 children have a developmental delay. This is based on what the caregivers told us, and they were told by a healthcare provider or educator. And that's 104,000 children across the 8-county service area. And for learning disability, 1 in 8 children has a learning disability. That's an estimated 138,000 children. Again, the concern that COVID had a large role in this and not allowing children to have that opportunity to be social for a period of time, and that missed an opportunity to catch any developmental delays or disabilities. But others in the community had signified that they would like to see more screening to help catch those developmental delays or autism in the younger children. Next slide. Now we'll focus on mental health. And for this, we'll look at children ages 6 to 17, school-age children. And if we look at what the caregivers told us, this is based on what they were diagnosed with. 1 in 3 school-age children has at least one of the most commonly diagnosed mental health conditions. Those mental health conditions are listed here. So anxiety, depression, ADD, ADHD, or behavioral or conduct disorder. So 1 in 3 children has had at least one of these diagnosed. That's an estimated 268,000 children in our 8-county service area. Now, there may be children who have one of these conditions, but has not yet been diagnosed. And according to our community leaders during interview, they said that sometimes kids can show depression differently than what we would expect for adults. They can show it with irritability, they could act out or be aggressive in the classroom, and that's hard for school administrators. Others, if they have ACEs or any kind of childhood trauma, that could also manifest here. Others were concerned that social media, bullying, cyberbullying, any of those types of potential stressors were exacerbating what the mental health needs were in the community. And others connected that if there were more outdoor activities or more encouragement to do outdoor activities, that would help mitigate some of those concerns. And then, of course, mental health was definitely impacted for all of us with the pandemic. It's been tested according to this community leader. And as a result, they're focused on suicide prevention, access to food, and youth resiliency. Next slide. So if we look at the learning section and we look at equity gaps, if we look at our survey responses by income, we see that those that are in the 50K or below were less likely to be developmentally ready for school, according to their caregivers. And those below 100K were more likely to have a developmental delay or learning disability. If we look at our responses by race and ethnicity, non-Hispanic white children were more likely to have at least one of those most commonly diagnosed mental health conditions. Now, if other children have limited access to healthcare, this could impact prevalence rates based on what caregivers told us, meaning there could be children across our community who have mental health needs that have yet to be diagnosed. For our non-Hispanic Black and Hispanic children, they're less likely to be developmentally ready for school based on what caregivers told us. And for non-Hispanic Black children, they were more likely to have a developmental delay, according to a healthcare provider or educator feedback that caregivers reported to us. Now, for our underserved population, this finding was something I'd like to point out. Where in all the other areas we've mentioned so far, our underserved population sample size tends to have more health needs. However, if we looked at these ratings for our underserved population, their estimates are more favorable, meaning they're reporting that they're more ready for school and they have less developmental delays or learning disabilities. But when we think back to what community leaders told us, and that quote we saw in the earlier section, that there are a lot of parents in this group who are afraid to receive care or pursue care for their children for fear of being reported or deported. So these estimates for the underserved population may be higher if access to care was not a factor. Next slide. So to summarize the learning section, how do we help every child with their learning? And that includes providing awareness of developmental screenings, awareness of mental health and services, and resources for coping, resiliency, and suicide prevention. From our community leader, again, a positive quote, because there was so much effort here to help children in the learning environment, especially during the pandemic. We make sure we have a social worker on each campus this year in particular, due to the increase in these types of needs. These kids cannot focus on learning if their basic needs are not met. We want to be sure they are all provided with existing community resources. And this was a theme that was common throughout leaders, and even what we heard from parents is that schools were responding. And so next slide. Our last section is the parenting section, and that's the parenting and family support element of this. We have caregiver coping with parenting demands, and caregiver has a source of emotional support as metrics from our caregiver survey. Next slide. For the parent coping question on our caregiver survey, we asked parents to tell us how well they were coping with the daily demands of parenting. They had 4 options. And so here we're looking at those that picked the best category, which is very well. If we look at this from our 8-county service area, 1 in 2 children has a caregiver who is not coping very well with parenting demands. That's an estimated 584,000 children in our 8-county service area. And the trends in caregiver coping very well is that we could look at this rate compared to the US and Texas benchmarks. And so before and during the pandemic, we've seen that that rate has steadily decreased since 2015. So there's many factors that could be contributing to this rate. We also see that the lowest rates are for caregivers of children ages 12 to 17, and that the lowest rates are among caregivers who are separated, widowed, never married, or divorced. And if we look at what our community leaders told us and what parents told us in their focus groups, those that were single parents were exhausted from trying to manage everything and provide attention to their children. And others were concerned that the COVID stressors could be a source of stress for the family and could cause arguing. And then others were saying, and this is a parent quote, that if the parents were unable to just provide for basic needs, how are they going to be able to provide for outdoor activities or sports, or even get them there, or get the physical activity needs there and get the nutrition that they need? And that could ultimately create a snowball effect. Next slide. So if we look at emotional support, and we look again at our children 0 to 17, based on our caregiver survey findings, we see that 1 in 7 children has a caregiver who does not have a source of emotional support to help with their parenting. That's an estimated 171,000 children. Now, when we looked at a follow-up question for the children that have caregivers that do have that emotional support, they told us that those were most likely to be other family members or a close friend, a spouse or domestic partner, a place of worship or religious leader, healthcare provider, or a peer support group. And on the focus groups with parents, we heard emotional support. I don't really know. I attend church group meetings, and that's about the only support I have. Others said financial stress, emotional stress. That could be a real source of stress, especially if families don't have emotional support. And if a parent lost a job or parents were fighting in front of the child, this could be a potential ACE for children, adverse childhood experience. And if that were the case, were these children more likely to engage in risk behavior or substance use or have mental health needs? Next slide. So if we look at parenting through the lens of equity gaps, and we look at those income levels, children in households below 100,000 annual income, were less likely to be coping very well with parenting or have an emotional support with parenting. And for our race and ethnicity category, to find equity gaps there, children of color, that's children who are Hispanic, non-Hispanic Black, non-Hispanic Asian, or non-Hispanic multi-race, caregivers in these groups were less likely to have a source of emotional support to help with parenting. And similar to what we saw in the learning section, our underserved population reported that higher rates of coping very well with parenting, yet they didn't have a source of emotional support. So there could be many factors in why we're seeing that result, but it is something noteworthy to share. Next slide. So to summarize the parenting section, how do we help every child and their family? So we want to provide that awareness of family support resources, equitable access to healthy food and physical activity, equitable access to healthcare to receive family-centered preventive care, health education, and assistance with social needs. And again, another positive quote that we heard from community leaders: organizations are pulling resources together. It's such a positive and uplifting thing, really profound to see. We also learned so much about available resources while connecting families in need with specific resources. Next slide. So to summarize the help section, where we've identified key community health needs and equity gaps, we can be reminded that all of these health topics are connected, and at the root of it are social determinants of health. And to help us remember that, as we're working with families in the community, we can help them with their health, environment, learning, and parenting needs, where we could ask how we could support them with equitable access to care and basic needs, safety where their children live, learn, and play, how to help them with readiness and support for school, and provide additional support for parenting and families. Next slide. All right, well, that was the HELP presentation where we identified those community health needs and our equity gaps across our 8-county service area. And with that, I will turn it back over to Becky.
Oh my goodness. Thank you, Blair. Blair has done a tremendous job, as you can probably tell, synthesizing all of our CHNA data. We like to say that she lives, breathes, sleeps our assessment data, and she just does such a wonderful job. We have been really excited to share this information with you all, and I hope Blair has given you some new or validating insights to think about. Although improving the health and well-being of children and families across our community is often complex work, we recognize the strong collaborative efforts and partnerships of so many individuals and organizations within our area. I have a few additional updates to share with you all before we close, but first, in the spirit of continuous improvement, we're going to pause for a few seconds and ask that you please scan the QR code or click on the link in the chat to take a very brief survey about today's event. So I will pause just for a few seconds while we do that. Thank you again for joining us today. We're actually running a little bit ahead of schedule, so we'll give you a few minutes of your time back this morning. Again, hope everyone is staying safe and warm. We will notify you when our full CHNA report is on our website in the next couple of months. We'll also email you a copy, all attendees today, of our CHNA executive summary over the next few weeks, so please keep an eye out for that. We now have our race and ethnicity crosstabs on our CHNA dashboard. So some of those equity gaps that Blair spoke about today, those you can now find that parent survey data on our CHNA dashboard, along with a lot of other great information. So if you haven't visited that, I do encourage you to do that. You can find that link on our Center for Children's Health website, and I believe they're going to share that in the chat with you as well. Please join us for our local county summits, beginning with Hood County next week. That will be a virtual event. You may find more information about this on our website at centerforchildrenshealth.org. And one final update that we are really excited about for our next community health needs assessment, we will now begin administering our parent caregiver survey annually. So instead of waiting 3 years to capture this data again, each year, over the next 3 years, we'll collect our survey information from parents and caregivers annually, and then we will update our dashboard with those yearly results. We're excited to provide more real-time results with you to hopefully explore more trends moving forward. So the next parent survey will begin administration in the next few weeks. We thank you for your time today. This concludes our summit. Again, if you have any questions, please reach out to us at chnafeedback@cookchildrens.org, and we hope to hear from you soon. Thank you very much.